The treatment of cancer-associated thrombosis from guidelines of clinical practice. We all know that cancer kills people. But do you know that cancer-associated thrombosis is one of the leading causes of death in cancer patients after cancer itself? Cancer alone is associated with a four-fold risk increase in the blood clots, and if it is associated with chemotherapy, the risk increases to 7-folds. We all know the Virchow triad, and by applying the Virchow triad to cancer patients, we can find sometimes endothelial injury could occur due to tumor invasion, chemotherapy, venous catheter. Also, venous stasis occurs with immobilization, tumor compression, and the changes in the viscosity. And of course, cancer patients has hypercoagulability. Many risk factors are included in the risk for VTE, may be treatment-related or cancer-related, patient-related, and biomarkers. The highest risk of DVT is with hematological malignancies, followed by the lung and GIT cancer. And due to their high incidence, the prostate in men and the breast in women contributed most heavily to the overall burden of cancer-associated thrombosis. We can notice here the risk factor for cancer, or the risk for DVT with cancer is different during the course of malignancy. It's increased if there is surgery, hospitalization, or chemotherapy, then decreased with remission, and then increases again if there is metastasis, and the risk continues till the end of life. Let's get back to our subject of today, guidelines and clinical practice. If there is a gap between guidelines and our clinical practice, I will give an example. Enoxaparin, one of the most written drug by most vascular surgeons, it's those known to everyone. But let's ask, how many of us really calculate the body weight and prescribe the exact dose? I think most of us don't do this. So we are breaking a simple rule of dosing of the drug. In this presentation, we will try to fill the gap between clinical practice and guidelines. The presentation will be in the form of questions about the prophylaxis and the treatment of cancer-associated thrombosis. And the answer of this question will come from the American Society of Clinical Oncology Guidelines, which was published less than 6 months ago. The first question, is thromboprophylaxis is important for cancer patients? I think this does not need a guideline to answer. Of course, it is important. But the use of thromboprophylaxis in cancer patients can be considered in 3 settings. First, the ambulatory cancer patient, with or without chemotherapy. Then, if the cancer patient was admitted to the hospital with acute illness. Then, if this cancer patient undergoing surgery. For the first category, outpatient cancer patient, with or without chemotherapy. Is it routine to give him prophylaxis? The answer from guidelines, no. It should not be offered routinely for all outpatient with cancer. So which patient, which type of patient? We will choose the high-risk patient. How to know the high-risk patient? From one of the famous scores, it is called the Corona score. And which drug to use for prophylaxis? The guidelines said we can use either NOACs, and they named apixaban and rivaroxaban, or low molecular weight heparin. Also, if the patient has multiple myeloma, he should receive a thromboprophylaxis if he is taking a treatment like thalidomide or lenalidomide. This is the Corona score, and if we look for the first line, if the patient has pancreatic cancer or gastric cancer, he gets a score of 2, and this gives him a high risk degree to receive thromboprophylaxis. Should hospitalized patient with cancer receive anticoagulation for VTE prophylaxis? The answer is yes. All hospitalized patients with cancer and they are admitted because of severe illness, they should receive thromboprophylaxis. But this on condition that there is no bleeding tendency or no other contraindication. And if the admission was due to minor procedure like infusion of chemotherapy, they should not receive thromboprophylaxis. The most important for us as vascular surgeons, should patients with cancer undergoing surgery receive perioperative VTE prophylaxis? The answer is yes. All patients with cancer undergoing surgery should receive thromboprophylaxis. And they named low molecular weight heparin as a drug of choice for this prophylaxis, and the treatment should be continued for at least 7 to 10 days. But if the patient have abdominal or pelvic surgery, the treatment should be extended to 4 weeks. What about the timing and dosing regimens for prevention of VTE in patients with malignancy undergoing surgery? There are 2 regimens. We can give 20 milligram 2 to 4 hours pre-operatively, and then continue with 40 milligram once daily thereafter. Or we can give 40 milligram 12 hour pre-operatively, and then continue also with 40 milligram once daily thereafter. And the first dose after surgery should be administered from 6 to 8 hours post-operative. One of the major concerns, and we should take care about, is the epidural anesthesia. If epidural anesthesia is planned for a patient who is taking anticoagulation, it should be stopped at least 12 hours before the insertion of epidural catheter if he is taking a prophylactic dose. And if he is taking a therapeutic dose of low molecular weight heparin, the epidural catheter should not be inserted unless 24 hours after the last dose. And after surgery, the catheter should not be removed at least 12 hours after the last dose. And after catheter removal, the first dose of low molecular weight heparin can be administered no earlier than 2 hours after removal of the catheter. This was the prophylaxis of VTE in cancer patients. What about the treatment? The treatment of cancer-associated thrombosis follows the same principle of deep venous thrombosis, but there is a difference. Because the efficacy and the safety of anticoagulation are not the same in cancer patients. There is more risk of VTE recurrence and there is more risk of bleeding. And here comes a question: what is the best method for treatment of patients with cancer with established venous thromboembolism? Initial anticoagulation, the guideline said we can give low molecular weight heparin, unfractionated heparin, fondaparinol, or rivaroxaban. And for long-term anticoagulation, we can give low molecular weight heparin, edoxaban, or rivaroxaban for at least 6 months. We can notice here there is no place for vitamin K antagonist or warfarin, because vitamin K has problems like narrow therapeutic window, many drug interaction, delayed onset and clearance of action, and frequent blood sampling, and this is not suitable for cancer patients taking chemotherapy. Another guidelines, we all know the ACCP guideline, they named for no cancer patient, they named the NOAC as the first line of treatment. But when talking about cancer patient, they named low molecular weight heparin as the preferred method of treatment. The International Society of Thrombosis and Hemostasis, they named specific NOACs. They say edoxaban and rivaroxaban can be used for the treatment of VTE in cancer with low risk of bleeding and no drug-drug interaction. But low molecular weight heparin is preferred in patients with high risk of bleeding, like patients with luminal GI cancer and intact primary, patients with cancer of the genitourinary system or bladder, and patients with active GIT mucosal abnormalities such as duodenal ulcer, gastritis, esophagitis, and so on. There is a difference if you are taking NOACs orally, because here we introduce an active drug to the GIT mucosa, and this explains the high incidence of bleeding with NOACs in cancer patients, because the incomplete absorption, they act like a topical anticoagulant over the gastric mucosa. Some NOACs, like the dabigatran, have a direct caustic effect, and we all know that NOACs also inhibits the mucosal healing. If we are prescribing NOACs for cancer patients, we should take care of the drug-drug interaction, because many chemotherapeutic agents play a role in inhibition or induction of the action of NOACs. Is 6 months is sufficient for a patient with DVT and cancer? Extension of treatment is prescribed for patients with active cancer, like if there is metastatic disease or receiving chemotherapy. But long-term anticoagulation should be assessed periodically, because the risk of bleeding can be increased or decreased according to the patient situation. In our practice, we see a patient with DVT and the diagnosis of DVT, and then prescribe him a treatment, and then the patient comes after a few months with cancer. So here comes the question: is deep venous thrombosis can be used for screening of occult malignancy? We all know Armand Trousseau. He said in his textbook in 1960, "I have always been struck with the frequency with which cancerous patients are affected with painful edema of the superior and inferior extremity." والغريب ان ارموند تروسو نفسه لما حصل له كده عرف ان عنده كانسر ومات بعدها بكذا سنه بجاستريك كانسر. طيب هل نعمل سكريننج؟ عيان جالنا عنده دي في تي ايديوباثيك دي في تي وشاكين ان في كانسر، هل نعمل سكريننج فور كانسر؟ جايد لاينز قالت ان it is not recommended for screening of cancer in VTA patients. This is the conclusion of the guidelines, as we said before, and thank you for listening.